Our talk today will be about spontaneous coronary artery dissection. I am Khaled Hamada, lecturer of cardiology, Kafr University, Egypt. First definition, SCAD is a non-traumatic, non-iatrogenic, non-atherosclerotic separation of the coronary artery walls, creating a false lumen either between the intima and the media, or the media and the adventitia, which compress the true lumen and cause myocardial ischemia or infarction. The incidence of SCAD is variable between studies and registers, ranging from 0.8 to 4% of patients with acute coronary syndrome. SCAD may be underdiagnosed because of misdiagnosis with angiography, and the cases that may present with sudden cardiac death that could be missed with no post-mortem examination. More common in females, about 90% of cases, responsible for about a quarter of acute coronary syndrome in females less than 50 to 60 years of age. However, reported range of age at presentation was 18 to 84 years. Mechanism. There are two hypotheses for the pathophysiology of SCAD. The first one, as seen in the upper part of the picture, the inside-out hypothesis, and the second one is the outside-in hypothesis. The inside-out hypothesis starts within the first wall, the vessel wall, by tear in the tunica intima, through which blood in the lumen tracks into the subintimal space, creating a false lumen which expands circumferentially and longitudinally and causes compression of the true lumen. The outside-in hypothesis starts with micro-vessel rupture in the tunica media of the vessel wall, with enlargement of the false lumen and the pressurization of the false lumen that can compress the true lumen. It can continue either as non-fenestrated with no communication between the true and false lumen as seen here, or with reverse intimal tear and rupture of the intramural hematoma into the true lumen with variable contrast penetration. The outside-in hypothesis is now the most widely accepted explanation for the SCAD because of angiography and OCT studies that shows on serial examinations that this type of SCAD with non-fenestrated SCAD and intramural hematoma is only present at the early stages of SCAD that can subsequently proceed to the second type, non-fenestrated or fenestrated type. These are histological and gross pathological pictures of the SCAD appearance with false lumen shown in here and here as intramural hematoma compressing the true lumen. Risk factors and these associations of SCAD, female sex and pregnancy, especially multiparous women, and fibromuscular dysplasia. The fibromuscular dysplasia is a non-atherosclerotic, non-inflammatory disease of the arterial walls that can lead to dissection, stenosis, or aneurysms affecting many vascular beds like coronary, renal, cervicocephalic, and visceral arteries in middle-aged females with low cardiovascular risk. Fibromuscular dysplasia with extracoronary affection was documented in 41 to 86% of SCAD cases. As we can see here in this picture, there is affection of the renal artery with classic string of bead appearance with alternating areas of stenosis and aneurysm. Also, there is here affection of the external iliac artery with localized dissection, and here affection of the carotid and vertebrobasilar arteries with aneurysm formation. Extracoronary lesions are mostly stable and only needs follow-up imaging. It's asymptomatic and may add low-dose aspirin in case of persistent dissection. CT angiography should be done in all SCAD patients to exclude the presence of FMD. There are also genetic variants associated with SCAD. There are some common genetic variants and some rare genetic variants. As we can see here, the factor 1 gene is not only associated with the SCAD, but also with the fibromuscular dysplasia. Here, the COL3A1 gene is associated also with vascular Ehlers-Danlos syndrome. FBN1 gene is associated with Marfan syndrome, gene mutation. Also, SCAD was reported in multiple connective tissue disorders and mechanical stressors and exercise like Valsalva type maneuvers and isometric or extreme exercise that is more common in men, emotional stressors that is more common in women, COVID-19 infection and mRNA vaccinations. There are case reports associated with SCAD. Clinical manifestation. SCAD should be suspected in a young patient who present with coronary syndrome or cardiac arrest, especially females with no or low risk factors for ischemic heart disease. Incidence of STEMI versus non-STEMI is variable between studies. with incidence of STEMI ranging from 26 to 55%. Also, 2 to 10% may present with sudden cardiac death. Diagnosis may be delayed because of low index of suspicion of acute coronary syndrome in this young group of patients with low prevalence of traditional risk factors for ischemic heart disease. We can do 12-lead ECG, high-sensitive cardiac troponin with serial follow-up.
Yeah, okay, but
Echocardiography
sorry, excuse me. The ECG and troponin are not part of the diagnosis of SCAD. What does it mean? They are used in any patient that is entering the hospital for acute coronary syndrome. So they are not able to rule in, rule out any SCAD. So, and the same for echo, nothing to do with that. Yeah, but that's something that you do always in an ACS patient. And they are not helpful in rule in, rule out. The only thing is to do imaging. That's the only hope to do this. It can be a non-invasive imaging with a CT scan. It can be during angiography, OCT, IBUS, whatever. But that's the diagnosis. Under this label diagnosis, you cannot put ECG, troponin, and all of that.
Okay, thank you. As Dr. Cortese mentioned, the invasive coronary angiography is a gold standard for diagnosis. Also, coronary CT angiography can be useful, usually for follow-up. The SCAD classification on coronary angiography, known as the IPSO classification. There are 4 types of SCAD. Type 1 with contrast staining of the false lumen with formation of double or multiple radiolucent lumens. Type 2 with long and diffuse smooth narrowing of the coronary artery. Type 2 can be subclassified into type 2A with normal proximal and distal segments of the diseased segment, and type 2B with extension of the SCAD to the very distal segments of the coronary artery. Type 3 with focal or tubular stenosis that can resemble atherosclerosis, and type 4 with total occlusion of the coronary artery. Type 2 is the most common angiographic type. These are angiographic pictures of type 1 here, and type 2 and 3 SCADs. Type 1 here with formation or staining in the false lumen. Type 2 here with long smooth narrowing, and type 3 here with focal tubular stenosis that resemble atherosclerosis.
So, Khaled, wait a second. Wait. Stay on this slide.
I'm waiting.
So I would like to have a comment by the fellows. So, which is your idea? These are, I think, clear images of SCAD. They are very nice. And once you have seen this, it will remain in your mind that this is clear signal of type 1, type 2, and type 3 SCAD. I would like to know which is your experience on this. So, who is iPhone? We have one iPhone.
I am
016.8. Yeah, you are the other iPhone. I was reading the other iPhone. Krupal. Okay, so. Okay, do you want to comment, Krupal or Wojciech, on this?
So what can I? It's not quite often situation in our cath lab, but from time to time we have. I remember one patient of such patient with no, maybe not one, but some patient with SCAD. However, it is quite important point to when we decide to do the angioplasty, when to be sure that wire is in the true rumor. And what I had in the last case, I had the problem to catch the true lumen, and I put the I gave the heparin for one day, and after that I performed the control angio. And it was very easy to find the true lumen. So it is my experience with SCAD.
This is a trick for how to manage it. I think that Khaled will go through the indication and the treatment, I think, in a later stage. So now we are dealing with the diagnosis of SCAD. I think that this is still I was here with Riccardo Costa, and this is still an underdiagnosed condition, especially in a high volume center. Sometimes you rule in, rule out atherosclerosis, and some SCAD can be missed. Okay, type 2 here is quite clear. So if you have seen it once, you will always remind that. But some others, type 3 is complex to rule out atherosclerosis. So this is an important thing. So the diagnosis of SCAD is still tricky and complex. This is my opinion on that.
Yeah, I agree. I think sometimes I tend to, if you see this, you give GTN if the blood pressure is okay, just to make sure it's not like spasm, because sometimes you can get spasm that presents that might look similar. Bridging, particularly in the mid LAD, can, I mean, if bridging is clearly obvious, but if you got very severe bridging, you might confuse that. But yeah, it's a challenging one. But I guess, if you got TIMI3 flow, I tend not to instrument them. So unless the patient has persistent ST elevation or chest pain, if you have TIMI3 flow, like all of these three, I don't put a wire down. I tend to
this
like
is
what Checkers does.
This is part of the treatment. I don't want to spoil the presentation by Khaled, but on the indication, I think we can move on. Khaled, please.
Okay, thank you. I was saying that not all SCAD presentations fall in this strict classification, and some SCAD cases can show hybrid presentation between type 1 and type 2. So another simplified description has been proposed by Motref et al. That described the SCAD appearance on angiography as like a stick insect with compression here of the true lumen with biconcave borders, or like radish plant appearance where there is near total occlusion of the vessel. Affected vessel, LAD is the most common, followed by LCX, RCA, and left main. SCAD usually affects single vessel, but multi-vessel disease can present up to 13% of cases. Classically, it affects mid and distal segments and starts and ends at origin of side branches, which may act as anchor points that prevent further SCAD extension. Differential diagnosis of SCAD, as was mentioned by Dr. Baharat. Many coronary angiography patterns can look like SCAD. First, contrast streaming can give linear appearance similar to SCAD type 1, which can be resolved by increase of injection pressure with caution, of course. This is an image of contrast streaming in the distal RCA, which was resolved by increasing the injection pressure. Also, coronary spasm can be resolved by intracoronary nitroglycerin. Iatrogenic dissection, here history of coronary previous coronary intervention is a clue. However, it's be noted that risk of iatrogenic dissection is increased in patients with SCAD due to fragility and weakness of the arterial wall. So initial non-selective injection can reduce this increased risk. Also, coronary embolism, which can be occlusive and looks like SCAD type 4. Here, truncation of multiple branches due to shower of embolic material can give a diagnostic clue towards the coronary embolism. And the coronary embolism also can be non-occlusive, similar to SCAD type 1 appearance. Here, intracoronary imaging is needed. Finally, atherosclerotic plaque rupture can look like SCAD type 3. Here, intracoronary imaging also is needed to differentiate if the patient is stable. Intracoronary imaging use of SCAD can be used to confirm the diagnosis if the diagnosis is uncertain by coronary angiography, also to guide intervention if needed to confirm the true guide wire and stent position in the true lumens. Available modalities, OCT and IVUS. OCT now is the gold standard because of its high spatial resolution, regardless that it needs contrast and it has lower light penetration. The IVUS has the advantage that it doesn't need contrast and has high penetration depth, but because of low spatial resolution, it comes second to OCT. These are classic pictures, A and B and C, of IVUS images of SCAD patients with classic appearance of intima medial membrane as white lines. However, this may be not evident in all pictures or all patients of SCAD because of low spatial resolution. And here's the crescent appearance of the false lumen behind the intima medial membrane as white line.
Please come back to
OCT
the
images
IVUS. Hello, come back to the IVUS, please. Yeah, so doing imaging with SCAD with IVUS is truly complex. Hi, Ricardo, you want to join? Okay, sorry. it's truly complex. So in panel C, you can see quite clearly the true lumen, which is compressed, but in the other ones, for example, in type A, how can you rule out atherosclerosis? Just this binary. In a routine way, it's very difficult with IVUS to, despite this is the Boston IVUS, which has a higher resolution as compared to the Volcano one. It's very difficult to rule out SCAD. It may be helpful if you have the clinical condition, the clinical characteristics, a young woman, for example, ACS, you have a high suspicion with imaging, with angiography, and then you do IVUS, then IVUS can add something, but it's very difficult. On the other hand, put the next slide, please. And on the other hand, we have OCT. Now you will describe this, it's fine. With OCT, it's much easier to do the diagnosis, but always remind that with OCT, you have to inject contrast at high pressure. And that can lead to a worsening of the dissection and the closure of the vessel. So you have to keep that very, very clearly in mind. It's not an absolute contraindication. We do OCT sometimes, but it depends.
Okay. So as we're saying, these are OCT pictures of SCAD lesions. Here in A, we have the compressed intima and media with false lumen, which looks like crescent appearance with heterogeneous appearance inside the false lumen itself. Here we can trace all boundaries of the external elastic lamina. Figure B is similar to figure A. However, due to poor light penetration, we cannot trace the full boundaries of the enlarged external elastic lamina. In figure C, we have like circumferential formation of the intramural hematoma with compression of the true lumen. In figure D, we have this tear or flap with connection between the true and false lumens. In figures E and F, the wire and the OCT catheter both are in the false lumen, which is very enlarged with compression of the true lumen, which appears slit-like. The risk of intracoronary injury in SCAD is low but definite risk. In a retrospective study by Robert Jackson et al. Of 63 patients diagnosed with SCAD where OCT was used and angiographic images were available before and after OCT, imaging related.
Ahmed, since the time is running, we already discussed about this. Unless there are questions on this topic, I think we can skip this. And let's go directly to the treatment. Okay, CT angiography can be an option, despite it's difficult, but I would say that the management is very important. We don't have to, we have to be focalized on that.
Okay. The goals of therapy is to preserve myocardial perfusion and myocardial function. Initial management can be divided into conservative approach with the preferred initial approach in stable patients because most patients have a spontaneous healing when follow-up up to 100% of cases, or emergency revascularization with BCI or CABG. Here there is no rule for thrombolytics because it can increase the intramural hematoma. In patients with ongoing myocardial ischemia, hemodynamic instability, and left main dissection, emergency revascularization could be pursued. Long-term management consists of pharmacological, non-pharmacological, and repeat angiography. Spontaneous healing in conservative approach was documented and studied by So et al. All of 74 SCAD cases showed spontaneous healing on follow-up angiography. Also by Rogovaski et al. 29 of 30 SCAD patients showed spontaneous healing.
Wait a second. Stop. Take a breath. Come back to the previous one. Okay, so Jacqueline So is, I think, one of the most, the number one expert in the world for SCAD. So I'm not aware of this publication. Yes. So I wanted to understand. So she managed 74 SCAD cases conservatively, but all of these cases came with acute coronary syndrome. This is my first question. The second one, did she do angiography and imaging in all of them? And how many cases had a complete closure of the vessel instead of some disease?
Okay, this was a retrospective series. I think the number of cases was larger than 74. Only 74 SCAD cases were managed conservatively and had coronary angiography in clinical backgrounds. Other patients
we
may have
need to
coronary
see.
angiography like for all.
No, we need to see this, because if you
I
say
don't
that it's a
have the
retrospective
study now.
study, and if it's a super selection of cases out of a larger database, so you cannot present this message, because from this, as you presented now, you mean Jacqueline So, the first experienced operator
Yes,
of
Jacqueline So.
SCAD, is saying that you should not treat SCAD. This is different, because if you say that these are super selected,
stable patients, yeah.
Yes, but if you say that these are super selected cases, we need to go into the paper. So can you share here in your screen the paper?
Yeah. Okay, I will look for some.
Yeah, so we can understand it better. All right. So this paper was published, yes, when?
In 2014.
2014, okay. So retrospectively and prospectively, Vancouver, no, okay. SCAD has a professional experience interventional cardiologist, okay. Baseline. So we prospectively evaluated 168 patients. Average age was 52. All presented with myocardial infarction. ST elevation 26. Emotional, physical stress.
Yeah, but you see, after the patient, you said only 160 has been treated with conservatively, it says here, no?
And I was reading.
Yes, but not
so
all
majority
patients have follow-up angiography.
Were initially treated conservatively, the majority, 134 out of 168.
168, yeah.
Overall, 6 of 168 had coronary bypass, 33 PCI. Of those treated conservatively, 134, 3 required revascularization, and all 79 who had repeat angiogram more than 26 days later had a spontaneous healing. 2-year major adverse cardiac events were 16.9 and 10.4. So this is the study that you were referring to?
Yes.
In the presentation? Okay, so you can see here that as you presented from what we have seen is quite different. Okay, because these 74 patients were super selective among the entire database of the patients. Some of them underwent revascularization, some of them other. They decided, according to their experience, to treat conservatively some patients. We would like to understand which were the parameters that they decided to use to treat these patients conservatively. And then this is the fate of these conservatively treated patients. So this is the way I would have presented this paper.
Okay.
Okay.
Thank you for the comment.
Yeah.
There are no available randomized controlled trials to compare conservative versus emergency vascularization in patients with SCAD. However, observational studies shows that initial conservative approach showed similar mortality and the cardiovascular events similar to emergent revascularization with lower target lesion revascularization. In a meta-analysis and the meta-regression study, 1,720 patients, SCAD patients, were included with mean follow-up time of 28 months, as shown in the figure of the results. Only target lesion revascularization or target vessel revascularization showed a better outcome with conservative strategy, with odds ratio of 0.5. All-cause death, cardiovascular death, myocardial infarction, heart failure, and SCAD recurrence were not different. Risk of PCI in SCAD patients, iatrogenic dissection, either catheter-induced or guidewire-induced, hematoma extension, main vessel or side branch occlusion, need for long stenting with higher risk of in-stent restenosis, and the resolution of intramural hematoma behind the stent with risk of stent malposition and theoretical increased risk of stent thrombosis. However, no clinical event of such case was reported. Here, an example of stenting in type 2A SCAD patients, which resulted in hematoma extension as the proximal segment of the SCAD segment. Technical tips in BCI in SCAD patients: use of coaxial wrist aggressive guiding catheter with initial non-selective injection can reduce risk of catheter-induced dissections. Also, some operators prefer femoral access because radial access was associated with threefold higher risk of iatrogenic dissection, possibly because of non-coaxial engagement. Also, use of intravascular imaging, especially OCT, as we mentioned before, to confirm guidewire and stent position. BOBA can be used with undersized balloon that can be enough to restore flow and allow for spontaneous healing. Use of cutting balloons with inflation of small and short balloons can help decompress the hematoma and reduce possibility of hematoma extension if stenting is needed. However, cutting balloons are large devices that can cause extensive vessel injury, so caution is needed. Use of bioabsorbable vascular scaffold offer temporary scaffolding for the diseased coronary segment with resolution of the scaffold after 2 to 3 years. Long stenting allows stent expansion force over a wider area, so decrease possibility of hematoma expansion. Also, targeted stenting to seal proximal or distal edges of the dissection before stenting the mid-segment of SCAD, and drug-coated balloons. On reviewing the literature, there was a concern for impaired vessel wall sealing and hematoma expansion, given the weaker vessel wall and absence of medial fibrosis, which can limit the hematoma expansion compared to that of atherosclerotic coronary artery disease. There was a case report by Landy et al. That showed intimal flap sealing and healing of SCAD in OM branch with a problemless drug-eluting balloon with confirmation of spontaneous healing by CT at 1 month follow-up. Here I would like to hear your opinion, Professor Cortesi, about use of DCB in SCAD patients.
DCB is eluting an anti-restenotic drug, which can counteract the barotrauma-induced hyperplasia and also atherosclerosis. We have shown it. I'm not sure that it's a good treatment for SCAD. I don't see the rationale. I think that
you haven't used it before?
Yes, I've used it. I was coming there. I think that stenting is a contraindication unless you have an occluded vessel, or as Bharat was saying before, patients still with symptoms, STEMI, all of that. So then you have to do something. We have published 10 years ago or something with one of my fellows, a case series of cases where we didn't want to put a stent, but we used a DCB for SCAD. But that's just because it was the last chance, last treatment. So this was our thinking. We want to avoid stenting because stenting, due to the squeezing of the hematoma, can result in need for additional stenting, and then you go with a Chemin de fer. So we want to avoid in those cases, those super selected cases. If we do POBA just to reopen the vessel because the patient is symptomatic, that's fine, but you can have recurrences after POBA, 20-30% of recurrences. We can use cutting balloons, but at that time we were not so experienced with cutting balloons. Again, it was 2013 or 14, and we didn't want to use in this setting. So what can we do? We can use a POBA with a drug that potentially is associated with blocking the barotrauma and coming back with a lower restenosis rate. So this is why we did this case series. But currently, believe me, I don't use any DCB for this type of lesions because the rationale is still quite feeble.
Thank you. The procedural success in the Canadian SCAD registry, 106 patients underwent BCI, either with stenting or angioplasty. BCI outcomes, procedural success was defined as successful if BCI resulted in TIMI-3 flow with no residual stenosis that was present in 29.1% of the cases, partially successful in 40.8% of cases if BCI resulted in residual dissection or stenosis equal to or less than 50% of the lumen diameter and with final TIMI-3 or improved flow, unsuccessful in 30.1% if BCI resulted in residual dissection or stenosis more than 50% of lumen diameter, or worse in TIMI flow or extension of dissection requiring bailout cabbage. Another study used other parameters for procedural success. In STEMI SCAD patients, BCI success for STEMI SCAD was defined as improvement in baseline TIMI flow by at least 1 grade or maintenance or improvement of TIMI flow grade 2 to 3 and residual stenosis less than 50%. Here, procedural success was achieved in 91% of cases. Cabbage is indicated when BCI is unsuccessful or non-feasible, like patients with left main or severe proximal two vessel dissection. Procedural success in the Mayo Clinic retrospective study, out of 34 intended bypass targets, only 2 couldn't be done because of extensive dissection, with clinical follow-up in the Mayo Clinic retrospective study in hospital mortality was 0. However, on follow-up angiography of 11 patients, after 3.5 years, only 5 of 16 grafts were patent, possibly because of spontaneous healing of the native vessel and the competitive flow, or improper graft anastomosis. So it is advised to use venous grafts in SCAD setting to save arterial grafts for the future. The pharmacological treatment, currently no randomized control trial to assess medical treatment of SCAD patients. It can include antiplatelets. There are factors with use of antiplatelets SCAD patients. Although thrombosis is not the main mechanism of ACS and SCAD, OCT studies found luminal thrombosis in about 30% of fenestrated SCAD and 14% in non-fenestrated SCAD. ACS status promotes thrombosis regardless of the underlying mechanism of vessel closure. However, antiplatelets can prolong bleeding time and increase the size of intramural hematoma. Antiplatelets may increase bleeding risk, especially menorrhagia in premenopausal women. Recommendations. If the patient underwent stenting, 12 months is DAPT according to ACS guidelines, followed by aspirin.
Yeah, that's normal. That's normal. It's a stent, so it's nothing new. It's normal. If you have a stent, you follow the guidelines.
Yes, in conservatively managed patients, both the ACC position paper and the American Heart Association scientific statement on SCAD didn't specify a specific duration of DAPT following a SCAD event and recommended individualized approach. They prefer clopidogrel in comparison to more potent B2Y12 inhibitors like TICA and prasugrel. Some expert opinion recommend DAPT for 1 year, while others recommend 1 to 3 months DAPT followed by single antiplatelet for 1 year. What's your opinion about the duration of DAPT?
There is a study. It's a retrospective study with some prospective in certain patients. So this hybrid type of studies, whose first name is Enrico Cerrato. It's called the DISCO study. It's mostly a Spanish center study, which shows that, again, with many methodological flows, a DAPT should be recommended for majority of SCAD patients. But if you speak to other, experts, I had several discussions. I am in the European Society of Cardiology group of SCAD, so I treat this type of disease since a bit, and so I have many discussions. The current position of the group is to avoid DAPT. Also, if you go for a conservative management, and this is related to the fact that you can propagate the bleeding. There is currently a study, a Spanish study, which is enrolling patients. It's a randomized study, which is testing DAPT versus single antiplatelet. So current consensus is to avoid DAPT, unless you have put a stent, of course. But there is this Spanish study ongoing, I don't know at which stage they are, which will give us more information in the next future.
Thank you.
Any other
Anticoagulation, once SCAD is
opinion on
done.
this? Because while you are speaking, there is a very active chat. You cannot see that, but people are sending algorithms. Bharat, Sandeep, they are putting slides, they are putting papers on that. Guys, you can speak now. So this is the
Yes,
right
please.
podium.
No, I think I was about to say that paper, but I think you already have shown that one 2018. There's an AHS statement, which is what we use most of the time. But I think Bharat also put some like a flow chart from Jacqueline Shaw's presentation.
Yeah.
I think the bottom line is very clear that if there is a flow compromise or a luminal stenosis, then you can do some POVA to establish some flow. But eventually, if there is no atheroma there's no point in putting in a DCB or a stent. But DAPT is something which is bit debatable, because if there is a troponin elevation, I personally would go DAPT, because most of these patients are young. They're like, in their 40s or 50s, or even some younger patients. So DAPT they can tolerate. In some patients, we have also given a GP2B3 inhibitors, especially when there is a slow flow and things after balloon. So yeah, I think that is my
The only thing, Sandeep, is that the problem is not the bleeding risk of this patient. The problem is to increase theoretically, again, I repeat, theoretically, the risk of propagation of the bleeding within the hematoma. So this is why Fernando Alfonso, for example, is personally contrary to this, and this is why he designed this study in Spain, just to see if DAPT can have some advantages over single antiplatelet. But currently, there is no clear data, but currently the group is against DAPT.
Yeah, in this patient, I tended to avoid 2B3A because I'm just, afraid of propagating the intramural hematoma. I've used cutting balloons quite frequently for those that I have, even before putting a stent. I just gently inflate, like a Wolverine to 6 atmospheres, just to fenestrate a little bit and decompress a little bit. Not enough to actually tear the vessel, but just to kind of puncture so that you can, this is all theoretical, but to puncture so you can fenestrate and release some of that blood that's stuck there before you put the stent in. And the other thing I do is I tend to do the edges first before doing the center. If it's a long, lesion. And the other recommendation that Jacqueline had was go 5 millimeters proximal and distal to where it starts, so that you don't get the toothpaste effect. Like you squeeze the toothpaste, it comes out. Yeah, so
I think that is a recommendation to take a longer stent. Yeah.
So her recommendation, based on her advice, is 5 millimeters on each side. So where you see the dissection start, you go 5 millimeters slightly longer.
Yeah. Another thing that I agree with you. So, okay, the key point is to understand when proceeding with PCI or not. That's the key point. Because sometimes the retrospective study shown by Khaled clearly show that you have a rate of failure which is quite high. It's 40%. So that's the key point. Understand when to stop or not. One strategy, I don't know if Wojciech is still here, has been underlined by Wojciech before in his single case. But that's a strategy that you can consider. If the patient, you have a very bad vessel, very bad one, diffuse disease, but the patient is stable, not very symptomatic. One thing could be to be conservative, to do heparin for some time, put the patient in the ICU and check him again after 1 or 2 days. That's another possibility to recheck it. And sometimes you have the evacuation of the large hematoma, and then you can just have the flap, the proximal flap, that can be fixed with a stent more easily than extensive stenting.
Yeah.
That's just a possibility. But evidence-based medicine here, you can see that is not very strong. So
I think the tricky one is if you have a 50 or 60-year-old that has it and has concomitant, arteriosclerosis, some plaque there, and then but I think the diagnosis is pretty clear usually. Like it's females, high adrenaline situation, high stress situation, that sort of demographic usually.
Yeah. Demographics is not helping for this type of disease, of course. Any other question or comments?
No. I think that's a good presentation, a good topic to discuss. What about if you have a spiral dissection? Sometimes happens either by a balloon. Sometimes you dilate, or sometimes you spiral dissection. In which case, sometimes we have just treated the opening of the dissection, just the proximal end. I don't know whether anyone wants to comment on it.
You mean with the cutting balloon or how? With the POVA?
No, it's either it's a catheter-induced dissection when you have this spiraling down with there's a flow compromise, or it's not like a SCAD, but it is something probably happens during a procedure.
Yeah, it's not spontaneous, but sometimes, there are patients that have a very fragile intima, and they are at risk of iatrogen. Some patients, you can do whatever you want in their coronary artery, so you can be bombastic. Some others are very fragile intima and media, and you just touch them, and they get this huge, very bad, also spiral dissection. Your hope is to have the wire already placed, because if you have to wire this type of dissection, can be very tricky. You may want to use a CTO wire that we use for surfing in the septal branches, because it's a 0.3 grams. But the SUO-03, it's only can help, but it's not the final solution to that. Sometimes you can fix.
Sandeep, yourself, which wire would you tend to use if you have like spiral dissection, or if you're thinking of intervening?
I tend to use more workhorse wire, because the problem with these slippery wires is that it will go where it wants to go rather than where you want it to go. And the most important step here is to image. You should not treat before imaging to make sure your wire is in the true lumen. Because sometimes you say, okay, I picked up the branches on the way in, so I know it is true lumen, but that can also happen in a false lumen. So I think once you place the wire, I think first thing you have to do is to imaging to make sure you're luminal before you do whatever you want to do stenting. Because there have been some cases where they have stented the whole false lumen, and patient has been probably more sick and died from those kind of procedures. So if you have a spiral dissection, it can happen anytime. Registrars are doing it, like fellows, they dissect the RCA or left main. It can happen to anyone. But the most important step is to secure the artery if you can distally. I tend to use more workhorse wire, like a Sion Blue or a run through, whatever, because I'm a bit worried taking all this Fielder FC or a pilot wire.
Yeah. I guess, Gabriel Gasparini, he published this sort of, I guess it's a registry, but showing 78 consecutive dissections. SUO-03 was the most successful wire in getting down. So I think,
because it's a very soft wire. It's not traumatic. It's not polymeric. It's hydrophilic, of course, but like the majority of the workhorse guide wires, you can use it and rotate it. I think it's a good idea. I use it sometimes. Yeah. So great. Great discussion as usual. Thanks a lot, Khaled, for this presentation. It's a big topic.
It's a big topic.
So,
I try to be
it's a huge topic.
Khaled, just very quickly, these patients, what is the recurrence rates usually? Did you come across, so if someone has had SCAD and they've recovered, then they come in the clinic and they ask you, what's my chance of getting it again? What should we tell them?
We participate. The problem with this patient is that some of them have only localized coronary artery disease, despite it's not an atherosclerotic one. Some others have this fibromuscular hyperplasia, which is associated also with peripheral disease, and on top of also other organs disease. For example, I was remembering I participated to a study, but then I moved from that hospital, and I know which was the fate of it, where we analyzed with a duplex scan all of the SCAD patients. We did a CT scan of the abdomen to analyze better the liver, not the liver, the spleen, because they are sometimes a systemic disease. One question is which could be the recurrency of the coronary disease, or which could be the fate of the patient overall due to a systemic disease.
Sorry, Dr. Khaled, why spleen? Why spleen?
Because there were some parameters studied by the University of Pisa, if I remember well, that could be associated with the risk of SCAD in the spleen. But I didn't go through that too. We just enroll patients with SCAD and send them. They had to do this duplex of the carotid arteries. They had to do the CT scan or the abdomen, the echo abdomen, the echography of the abdomen, and the blood samples. But now that I remember about this, I will send an email. This is Dr. Rosa from Pisa. I will send her an email to see if they have finished the study and if they came to any conclusion.
See, the thing is that in the UK we have 1 or 2 centers who specialize in SCAD. Like you may have heard of a person called David Adlan.
Dave Adlam.
Yeah, so he's based in Leicester, which is not very far from where I work. So if I have a young patient with SCAD, I normally send it to him. And he does all the things what you just said. We used to do things like femoral angiography and things to see if there's BD appearance. But I leave it to him now, and he takes care of these patients, and we follow them up, and they have a national registry. So they go on to some kind of study and everything. So I feel sometimes these patients are best managed with someone who does this regularly and have expertise.
Yeah, Dave is the chairman of the European Heart ESC group. Yeah, he's very experienced. And in Europe, I think he's number 1.
Easily. So I think if you have any of those in your region, I think it's better to refer to them because they get full analysis. As Bharat said, they will also give the recurrence rate and chances of this happening again. I think it'll be better for them to be seen by expert who deals with these conditions regularly.
Makes sense. Yeah.
Excuse me, how often you do the follow-up, like for this kind of patients, to know the recurrent rate and everything?
I think it's left to any center. Depends on how is this.
Also according to the results of the angiography, whether mentioned conservatively or with PCI.
Yeah, if it's a PCI, you put in the PCI control, PCI controls ambulatory, or if it's not easy. You should send them. But I would say if you go conservatively, 1 visit after 3 to 6 months, and then you see. But there are no rules on that, I think, from what I'm aware.
Okay, thank you.
Okay, thanks. So, Sarah, you can interrupt here the recording. I think we have finished because we
have 2 slides about pregnancy SCAD and the chest pain after SCAD.
Okay, please.
We have 1 to 2 minutes.
Pregnancy 1 minute.
Associated SCAD represent a minority of patients, most often present early postpartum during the first 4 weeks after delivery with more severe presentation, more proximal and multivessel involvement with more heart failure and lower LV function. Diagnosis similar to previously discussed, and the management conservative treatment is preferable. Recurrent SCAD risk is about 1 in 10 patients. Pregnancy after SCAD should be considered high risk, and unplanned pregnancy should be avoided. Post-SCAD chest pain syndrome, non-ischemic chest pain is common after SCAD in more than 50% of cases, more frequent in females. Usually symptoms improve over time, but can take up to 2 years. Careful evaluation is needed, and sometimes objective evidence of ischemia before proceeding to invasive coronary angiography.
Yeah, I'm putting here in the. Wait. You don't need to read everything. Let me put about the pregnancy. Pregnancy is an important topic for the SCAD. We did this publication. Let me see how can I put in the chat. Is it possible to add something in the chat so you can read it? A PDF. How can I put a PDF here?
I'm finished. I think you can share your screen. I can stop sharing my screen.
Okay. Yeah. But I can send it to you via email if you want. We did this publication because the pregnancy is one of the risk factors for SCAD in some patients. The first occurrence of SCAD is during pregnancy. So we did this publication with Dave, if I remember well, 1 or 2 years ago, and we published it on Circulation. And this is, I think, the largest case series on the use of the fate of SCAD in pregnancy. So I can send it to you if you want to see. But the problem here is the diagnosis and what to do, because the patient have the baby to deliver yet. So it's a problem. And the timing, you can see here, that is occurring mostly after the delivery in the first month. Look at here. I don't know why. Not before. Someone could expect during delivery because of the stress, high blood pressure, but not in the first month after delivery. That's strange.